Welcome to Care Transitions Today, Case Conversations, a podcast presented by the Association of Physician Leadership in Case Management and the American Case Management Association, where we dive deep into the world of healthcare case management and transitions of care. Today, we are joined by three physicians, Dr. Rebecca Severe, Dr. Sweta Singh, and Dr. Teresa Jacobs. Dr. Rebecca Severe is a hospital medicine certified physician serving as Medical Director of Care Management for Advocate Aurora Health. With a focus on utilization review, quality management, and program leadership, Dr. Severe is passionate about evidence-based medicine and collaborative patient care. Her expertise and commitment make her a valuable asset to the medical community and a compelling voice in the podcast. Dr. Sweta Singh, Medical Director of Case Management at the University of Michigan Medical School, brings a wealth of experience in hospital medicine and a strong focus on quality improvement and patient safety. Her dedication to medical education and commitment to enhancing healthcare make her insights invaluable to listeners eager to learn and grow in the medical field. Dr. Teresa Jacobs is a clinical professor of neurology at the University of Michigan and is a distinguished expert in neurocritical care. Her wealth of experience in teaching and research brings invaluable insights to our discussions surrounding a variety of intricate case scenarios. In this series, we'll explore the challenges and triumphs of real-life case studies, providing valuable insights for healthcare professionals and anyone interested in the intricacies of patient care. Whether you're a seasoned physician advisor, a dedicated case manager, or simply someone passionate about improving healthcare outcomes, Case Conversations is your go-to resource for compelling stories and expert insights. This is Care Transitions Today, Case Conversations.
Well, it's good to see both of you again. I've got a case I wanted to bring to you to get your opinion. It was one that we actually sparked some conversation between our team, our PAs. We've been doing a lot of what we call quality reviews, really trying to get, look for what our opportunities are and give our team feedback. So that's where this case came from. And so I'm curious to see what both of you think of this and how you would have managed it. So this one is a commercial payer. 42-year-old without a lot of significant problems. It was having some trouble with their knee, ultimately needed to undergo an elective arthroscopic knee procedure. And that was all done outpatient. That was about 8 weeks before they presented for the hospital stay that we're going to talk about. So that procedure appeared to go well. They followed up at about 1 month post-op. At that point in time, they were making some progress, still having some pain, but they were having some swelling in the area. So the orthopedic surgeon opted to do arthrocentesis and do a steroid injection. So all seems pretty normal. No other real complaints other than some discomfort in the swelling. Now, it ended up growing some gram. It was a corynebacterium that ended up growing out of there. So they called the patient. This was all as an outpatient. They were, getting some discomfort, a little swelling, but no other, major symptoms. They said, well, this could just be a contaminant based on it being a corynebacterium. And they offered the patient, they said, well, you could come back. I think it was like the next day and we'll re-tap it, or you could come back. It would have been about like 5 days from when they had the call back. Patient opted for the 5 days because they weren't really feeling too bad. So they come to the clinic, they tapped the knee again. And at this point in time, it had, again, about 12,000 cells with a predominance, I think it was like 90% of neutrophils. They just let the culture grow again. It grew out the same corynebacterium. So they then opted to set the patient up to come in for arthroscopy with an irrigation and debridement of this knee. And they did get went through the normal auth process. Because of the payer and it was requested as outpatient, there was no authorization needed for the case. So it came in as outpatient on the day of surgery. They later made it OBS afterwards. And then hospital day 2, it went to our first physician advisor. So what are you thinking? If you're the physician advisor to get the case hospital day 2, what would you want to do with the status? And like I said, commercial payer, it's observation at this point.
Rebecca, did they say why it was changed from OIB to OBS? Is that the standard procedure you guys use when you admit after a surgery? Because we would have probably admitted that as an OIB. based on their not being auth?
Yep. So that is a great question. We've spent a lot of effort this last year or two trying to clean that up and try to get our surgeons not to just put it in an observation order. Because oftentimes I think historically I felt like, well, I'm keeping them, I'm observing them, I should make them obs. And we had to do a lot of re-education around that. So yes, that was a rogue move out by the surgeon. My PA's first response on this was outpatient in bed that day when they got it. But so they were leaning that way. But I guess, what do you guys think? Would you go back to outpatient in bed when you got it on hospital day 2, or would you go towards inpatient?
Where IV antibiotics started?
Yes, they were on IV Rocephin. Yes.
How'd the white count look at this point in time, systemically?
Yeah, they were sitting, there was only one count, and it was not trending. It was 13,000. Vitals were otherwise okay.
Well, hemodynamically stable, no signs of spurs or anything like that.
Yeah.
No elevated lactate, no CRP or ESR or anything.
Yeah, I mean, nothing was really out of the norm, and no need for like IV pain meds either.
Given the IV antibiotics, I probably would have kept the patient then observation. But I wouldn't have taken them back to OIB because they were getting the IV antibiotics, requiring the nursing care and the intensity that's involved with IV administration of antibiotics. I would not have yet made them inpatient because I think that they're still within a time period post-operatively where getting IV antibiotics is important, but the medical necessity there just doesn't feel like it's enough for me to have called it inpatient. Sweta, what do you think?
When I'm listening to this case, it's like I'm starting to think from medicine perspective, right? Oh, knee with only some 12, like 15,000 WBC, so less than 50,000. So it's not truly a septic joint, but more like infected procedure. And at first, when I heard Corynebacterium, oh yeah, skin flora, but times 2, it's not skin flora, it's skin bug that got inside and infected. But at the same time, I'm thinking by now we should already have culture and sensitivities. So we should know what this Corynebacterium is sensitive to because of the time lag. And so somewhere it's not like if this patient was getting admitted because of septic arthritis, where they have to now wait on the cultures, it's an acute presentation, and then tailor and decide on IV antibiotics and the course, I would have been still more thinking inpatient, but I'm also inclined more towards observation because we already know the bug, we already know the cultures and sensitivities, we know what antibiotic choice. It's now just more of post-operatively coordination of care that this patient needs, and also making sure, like you said, there is not even like IV pain meds or other acute needs that this patient had. In terms of between OIB and observation, yeah, we do have patients, if they are coming in for their routine or expected monitoring, be on OIB with extended recovery if they end up staying overnight. But this one, because of it's not perioperative prophylactic antibiotic, but rather targeted, trying to treat the infection, I'm okay calling it as an observation and making sure, because we're also observing, making sure we did go in and did the debridement of infected tissue. Is there potential risk of them having bacterial translocation or getting systemic infection? So we're monitoring for that. So if I was the PA reviewing next morning, I would like to keep it observation, see what the plan is today. What is their next step? Are they, from the information before, ready to transition to the next step and get him out, or he needs to stay for whatever the next step in terms of infection workup or treatment is?
Yeah, this one for me I was kind of back and forth because I like, as a medicine doc, septic arthritis procedure, IV antibiotics, hospital, inpatient. But this one just had those nuances to it where it was this long outpatient course, more of an indolent presentation with a planned procedure for me that made it, kind of interesting. And we did we had a second PA review at the next day. They upgraded to inpatient. That was the day before discharge. I just looked at the case again today, and it looks like we're sitting with a denial, but the denial at this point in time is for lack of clinical. So we sent the clinical. We'll have to hear back from what the payer is thinking. But yeah, I think I've been getting, kind of different, I think this is a really great case for our team to say, I don't know that there's one right or wrong way. Was there some delay, in that getting ID on board? That was what one of my PAs felt. They're like, they should have had ID. They knew they were coming in for this. They should have had ID, on board from the very beginning if they wanted that to help transition to that outpatient IV antibiotics, set the course, that maybe that would have shaved a day off of the stay as well. So I don't know. This one for me had, some interesting points to it.
Curious, did they get the blood cultures and wanted to wait 48 hours to make sure that was negative? Because sometimes, what was the final antibiotic plan? Because those things also add. And so commonly for septic arthritis, the reason they're almost always inpatient is because one, all the intensity, and then in terms of blood culture monitoring and following up, and then heavy antibiotic course planning, making sure we don't put a line in someone who's bacteremic, right?
Yeah. The blood cultures were negative. They did have sensitivities from both of the cultures. They were consistent. It was sensitive to Rocephin. I think they ended up going with a penicillin for outpatient for another week of IV. And then they were going to then go to an oral for a longer duration, and probably that was going to be finalized with outpatient follow-up with ID. Yeah.
Will be interesting to hear from you, Rebecca, what the ultimate outcome was on this case.
Yes. I'll keep you guys posted.
That was an interesting case. Thanks for sharing that.
The Association of Physician Leadership in Care Management, or APPLCOM, was created to provide support and education for physicians in this field. APPLCOM is unique because of its connection to the American Case Management Association, focusing on the partnership and collaborative model of nurse case managers, social workers, and physicians in care management. ACMA has a rich 25-year history of supporting the case management field. AppleCom is inclusive of all practice settings. Membership in AppleCom also gives you access to all ACMA resources and benefits. Whether you're new to case management or have years of experience, AppleCom membership is valuable. Gain access to professional networking opportunities and resources. Visit www.applecom.org to learn more. Case managers, join thousands of your peers who have made the decision to further their connections, learning, and knowledge through ACMA membership. Access the Member Education Center with recorded webinars, CEs, and peer-reviewed articles 24/7. Visit www.acmaweb.org/membership to learn more. Let's continue with our next case.
I have a next case. Are you guys ready for it?
Sure.
So it will be I came into picture a little bit late in this. So this is a 73-year-old woman with a past medical history of HFpEF, so heart failure with preserved ejection fraction, severe aortic insufficiency, chronic kidney disease stage 3, COPD, diabetes, type A dissection status post-repair in 2006, complicated by hemorrhagic stroke without residual deficit, peripheral artery disease, and 6 sinus syndrome, so status post pacemaker in place. So patient was originally seen or was following with her cardiologist in a different hospital system. And they said, well, you have repeated admissions for this, so about 5 admissions in a year. And it is a valvular heart failure, right? So they referred the patient to the cardiac surgery. Cardiac surgery said, with all the complexity, and especially with your history of type A dissection requiring repair, and then had a complication with hemorrhagic stroke, you're not a candidate for an open heart surgery, so we recommend you come to our institution for evaluation for TAVR. So our cardiology TAVR team reviewed the patient and agreed, yeah, patient would benefit from TAVR, and especially given that this patient has significant risks with open heart surgery or procedure. And they also looked into clinical trials, and the patient was not a candidate for any clinical trials. So they requested the authorization from the insurance company for TAVR. Payer denied the authorization, and TAVR was scheduled to be, so patient was seen by our TAVR team on a month before the planned procedure. So closer to the procedure, the clinic kept trying, appealing, no response, or still denied the TAVR and the admission. Called the patient. Patient was tearful, said, I cannot live like this, has been in between, bouncing back and forth between the two cardiology teams and getting diuretic adjustments, still having worsening symptom. So was admitted for optimization. They again, on admission for this time, started on some IV diuresis, reached out to the payer, and still the case seems to be denied for TAVR and for hospital stay. Before I go any further, what questions do you have?
Yeah, I guess I'm surprised that you're struggling so much with this prior auth. I would, having gotten, I don't routinely do the bulk of our prior auth, peer-to-peers. Most of the time we defer that to our surgeons, but I do partner with my prior auth team for the tricky cases. So this is definitely one that I think they would have escalated to me, and I would have, really wanted to hear from the clinicians doing these peer-to-peers, what is the payer telling you? Help me understand why they're saying no. I mean, with some of these procedures, there's some technical aspects of, certain diagnoses, certain bits of information you need to, make sure you have and you provide them. Otherwise, it's kind of like a technical denial if you aren't able to check the box. I'm wondering if we're just missing something, one of those, but you need to ask the right questions and get the payer to tell you why they're saying no. I probably would, if I had a medical director at the payer, I would have been like, help me understand why you guys are denying this repeatedly. It seems very obvious that it's clinically appropriate. So yeah, where did you guys go with this one?
Teresa, do you have any questions? Otherwise, I'll keep going.
I already know this case, unfortunately, so I've got to kind of monitor what I'm asking as a result. But I too would have just been crazed if I had known about this case first, because I would say, how can a payer allow a patient to go on having symptoms, not be treated, not pay for treatment that is medically necessary as determined by cardiac surgery, because they may die if they do an open procedure? In my mind, that's not good. So sorry, I get a little bit emotional about this particular case, because I can just see this frail woman trying to get around through her day and being denied by her insurer for what would be considered to be a quality of life preserving procedure.
Yeah, it seems like standard of care. This scenario seems like all the other payers we deal with, they would approve this.
And that's where I think, and again, I wasn't involved here yet. So cardiology team reached out to our Office of Clinical Affairs team and our leadership team. Hey, what are the directions for me? We don't have the authorization, and we know how expensive TAVRs are. But if we don't do that, the only option I have to offer, or only thing I can offer this patient, is hospice. And it is extremely important because, like, this patient has worsening heart failure symptoms. We've been trying and adjusting diuretics, but clearly it's not working. And so contracting got involved, and we did end up getting some conversations started with the payer and TAVR happened. So later on, when I got involved is because like in the initial conversation, and that's where peer is not able to determine or well, not truly not able to determine, but they cannot deny life-saving procedures, right? It's more of what the discussion was around the coverage, according to my conversations with the peer. Then I was still curious when this came to me. Why was it denied at first place? So I'm digging more into that in terms of, so this was a Medicare Advantage plan. So even though it's a commercial payer, they go by, and in terms of what Medicare would cover for the TAVR, they have a list of indications. This patient's reason was severe aortic insufficiency, so that is not one of the listed diagnoses. And it doesn't mean, so if there were two ways we can still get this patient have TAVR be covered if this was a Medicare case, is if it was a part of a clinical trial that they were doing. Now, can we have clinical trials for a particular patient and like proving like this is effective? Yes, but at the same time, it's a time sensitive procedure, right? And in this case, it was the only option because patient was not a candidate with all the other comorbidities and complexity for an open heart, which is a standard of care. So that's where the conversation happened. And after several rounds of conversation with the medical team, this was then pushed to the third party review in terms of would they agree in terms of covering the TAVR or not and how to further deal with. Well, we did, I think then we did agree, like one, patient is sick. Two, patient required to be admitted because was declining medically and what helped was patient was actually being seen very closely and had at least once to twice a week clinic visits. And the weight monitoring and what patient could do just drastically changed within that 3 weeks. And that mention in the notes of like patient could at least get to the mailbox, now has trouble getting to the bathroom was helpful. So we did argue and were able to get the admission approved as an inpatient on the basis of heart failure, coding it from that perspective rather than from the aortic insufficiency, valvular disease, and then following that pathway and get the admission approved, covered, and the procedures then subsequently approved and covered. But I think the reason I wanted to bring this case is I was surprised to know things like TAVR, which are relatively new procedures. I think because we still haven't explored or have broadened the different in the diagnosis that it can be used for, can sometimes be challenging to then get them approved. But it's still important to still look at like from the admission perspective, right? Was it because their initial argument was looks like this was not an acute admission but more like a planned admission. And then I think having those telephone notes indicating like patient was too sick and was at verge of ED, but knew was already going to be admitted, so didn't end up in the ED and coming in through the ED route was helpful. Any questions? I know I've done a lot of talking here right now.
But I think you still would have, because we have this happen all the time with we do a lot of TAVRs at a couple of our hospitals, and they, it can take a bit of digging through to see how they got to the hospital, because oftentimes it's in the works, but then they'll fall apart very quickly and it becomes a more emergent, urgent, admission. get them stabilized. And then part of that, usually diuretics is, indicated, and then they get them stabilized, and then they'll opt to do the TAVR as part of that stay because they're just falling apart. And if they don't, they will never get them out of the hospital for very long. So those can be hard, but I think even if that was the case exactly for this patient where it became an emergent admission, I think though if your payer was still having trouble with the diagnosis, the principal diagnosis, driving the need for the procedure, you would still get caught up in a technical denial on this one. So I think these can be tricky, and I've had several really high dollar cases that boil down to this. And oftentimes I found where I'm not a coding expert, so I bring in my coding friends, we take a look at it, I bring in my denial experts and take a look at what are all the requirements and just see, is there something about the coding that we can compliantly change, or maybe we're missing a code, or sometimes there's just something about some of these obscure procedures where the coding's just off a little bit, and it's just that's what you need to go after, and it can be hard to fix. So did you actually were able to talk to the payer and get them to tell you what they were thinking around it?
You did.
Yeah, no, definitely it required the whole, like they say, it required the whole village. It required collaboration with contracting, coding, rev cycle, our appeals team, our pre-auth team. It was a collective effort. We involved the coding experts, the documentation experts, along with continued conversation with the payer and their medical directors and their team. It definitely helps to have that collaboration and involving the experts, and as soon as possible, like our coding and the documentation on these cases, where, like you said, they can be stuck on the technical part of the diagnosis that we are billing for and what we are coding for, compared to sometimes there are multiple reasons the patient's in the hospital, and they are equally important and equally acute needs, right? It's a vicious cycle. Heart failure is bad because of bad valve. Valve is bad, and that's part is, so they both are equally weighing reasons for admission, if that makes sense, right?
Yeah. Yeah. So again, you just have to kind of sort it out with your coder and the rules of how you can code your case. So yeah, a great case. I enjoyed that one.
And absolutely, like you said, making sure we stay compliant, because at the end of the day, we want to do right for the patient and stay compliant. Go ahead, Teresa.
I was just going to say, I recall all the emails flying back and forth and reading your letters, et cetera, about this case, which was, again, a little bit provoking from an emotional standpoint. When you think about being a physician, sometimes you cross your humanity with your physician position, and you just get a little bit upset with the system, because the system can't see to find itself on the human end of things from time to time. So good work, Sweta. Thank you.
Yeah, I had to write a pretty long appeal letter, but it was definitely worth it. And then I still appreciate the collaboration from the peer too. But definitely, initially, when I read the first email, I was like surprised as to what? Like, how can this case be denied? But just learning through the process was a good learning experience for me. Like, what does the denial mean? And what are they looking for?
Well, thanks, guys. We had another great session today. I enjoyed the cases. Thanks, Sweta and Rebecca, for your cases.
Yeah. Bye.
Thanks, Teresa. Thanks, Rebecca, for great discussion.
Yeah, thank you.
Thank you to everyone for joining us for another episode of Case Conversations. We would also like to thank Drs. Sabir, Singh, and Jacobs for sharing these interesting cases in these episodes. We would love to hear from the audience. Please join in on the conversation by visiting acmaweb.org/podcast, and don't forget to subscribe so you're notified when we upload new episodes. Until next time, this was Care Transitions Today, Case Conversations.